Today, I need to talk about something many parents don't realize. If you've had kidney stones, your children face dramatically elevated risk, and they need different dietary rules than children without family history. Genetic predisposition to kidney stones is real, powerful, and actionable if we approach it correctly. The genetic factors are diverse and significant. Hereditary hypercalciuria means genetically determined excessive calcium in urine. Cystinuria is an inherited disorder affecting amino acid transport. Primary hyperoxaluria involves genetic defects in oxalate metabolism. Renal tubular acidosis can be inherited and affects urinary pH. These conditions increase stone risk regardless of diet. A child with these genetic factors will have elevated risk even with perfect nutrition. However, and this is crucial, dietary modification still matters enormously. Genetics loads the gun, but diet and lifestyle pull the trigger. The implementation must start with identification. Family history assessment should be routine in pediatric care, but often it's not done systematically. Children of stone formers need baseline metabolic workup. This means testing before any stones develop, not waiting for a problem to occur. Preventive strategies should begin before the first stone forms, because preventing that first stone is far better than treating recurrent stones. Different metabolic stone types require completely different approaches. Calcium oxalate stones, calcium phosphate stones, uric acid stones, and cysteine stones each have distinct dietary recommendations. This is where 24-hour urine collection becomes invaluable. It reveals specific metabolic abnormalities guiding targeted interventions. In some cases, genetic testing is indicated, particularly when unusual stone types occur or when very young children develop stones. Let me outline family-specific prevention protocols. High-risk children need stricter fluid intake requirements than average children. We're talking about specific daily volume targets based on body size. They need specific dietary restrictions based on their particular stone composition and metabolic abnormalities. Regular monitoring is essential to catch early stone formation before it becomes symptomatic. This isn't optional for high-risk children. It's necessary preventive medicine. Family education often reveals gaps in awareness. I've encountered many parents who form stones but never realized their children were at increased risk. They thought stones were just bad luck that happened to them, not a hereditary tendency that could affect their children. Siblings of affected children need screening. If one child in a family develops stones, the siblings should be evaluated. Sometimes extended family patterns reveal hereditary syndromes that weren't previously recognized, leading to important diagnoses across multiple family members. The psychosocial dimension cannot be ignored. Anxiety about hereditary risk is real and can be intense. Parents feel guilt that they've given their child this predisposition. Balancing vigilance with allowing normal childhood is challenging. You want to prevent stones without making your child feel abnormal or overly restricted. When genetic counseling is appropriate depends on the specific condition, but for some hereditary stone disorders, genetic counseling helps families understand inheritance patterns, recurrence risks, and reproductive implications. The bottom line: if you've had kidney stones, tell your child's pediatrician. Ensure your children are evaluated and monitored. Follow preventive recommendations carefully. The stone you prevent in your child is worth far more than the stone you treat later.